This is a care report presentation on the subject of scoliosis by Jordan Gallus and Jessica Kemock for the University of South Florida SRNA students.
The objectives of this care report are to describe the pediatric case study, to discuss the pathophysiology of scoliosis, to list diagnostic criteria, to describe signs and symptoms associated with scoliosis, to determine altered system functions, to discuss treatment options, and to determine pre-op, intra-op, and post-operative anesthesia considerations. The case study being incorporated into this care report describes a 13-year-old adolescent girl who is 35 kilograms with an 85-degree thoracic scoliosis. She also suffered from Prader-Willi syndrome. She received past growth hormone therapy, and her doctors were waiting to restart this therapy after spine surgery was completed. She had an asymptomatic ventral septal defect with an LV ejection fraction of 62%. Her pulmonary function tests revealed a normal FEV1 and a reduced forced vital capacity, FVC, which was less than 78% of predicted. The patient had undergone previous general anesthesia for a non-spinal surgery with no complications. This case study examines how during her spinal surgery, on 2 occasions, following an uneventful induction and TIVA administration, the patient developed bradycardia and became hypotensive when flipped into the prone position. She was unresponsive to boluses of ephedrine and epinephrine. With each occasion, she was returned supined and the bradycardia resolved. The anesthesia team emerged the patient without any further complications. The echocardiograph, troponin, and CK-MB levels were all within normal range, and her ventricular function was good. However, since her scoliosis was progressive and they were waiting to restart growth hormone therapy post-surgery, it was necessary to urgently proceed with the intended spinal surgery. On the 3rd surgery attempt, after induction, a transvenous pacing wire was placed, and a TEE probe was inserted. Upon proning, yet again, she developed bradycardia. The bradycardia responded to the transvenous pacing. The case was continued without incidents. Bradycardia was concluded to be due to a hypervagal response provoked by both the prone positioning and the severity of her scoliosis. Children are parasympathetically driven, and this prone positioning caused excessive vagal stimulation, causing bradycardia and hypotension that was refractory to treatment with anticholinergics and vasopressors.
Scoliosis is defined as a lateral deviation of the normal vertical line of the spine, which is greater than 10 degrees when measured by radiographs. It affects a total of 2 to 3% of the population, with a varying age of onset that averages anywhere from 10 to 15 years. Scoliosis occurs equally among genders. Each year, around 600,000 visits will be made to primary care doctors for the assessment, diagnosis, and treatment of scoliosis. 30,000 kids a year are fitted with supportive or correctional braces, and 8,000 patients will undergo spinal fusion surgery. So there are many subtypes of scoliosis. We're going to expand on a few of these in the next couple slides. Congenital, infantile, and juvenile scoliosis are classifications based on the patient's age at the time of diagnosis. Congenital scoliosis is present at birth and is caused by failures of formation and segmentation of the vertebral bodies. The most common anomaly associated with congenital scoliosis is hemivertebra. This is a type of vertebral anomaly that results from the lack of formation of one half of the vertebral body. Congenital scoliosis also may be associated with the malformation of other bones and cartilages, such as the ribs, chest wall, and resultant hemifacial microsomia. These patients will have a 25% of urologic abnormalities and a 10% risk of cardiac anomalies. So bracing and casting are not effective for this form of scoliosis, and you can see the surgical options are listed on this slide. Infantile scoliosis is diagnosed between birth and 3 years of age and usually occurs in the thoracic spine, with the curve being convex to the left. Bracing and serial casting for infantile scoliosis can begin as early as 5 months of age. Juvenile scoliosis is diagnosed between the ages of 4 and 10 years and is mostly managed by bracing and surgery. So 20% of children diagnosed with any of these 3 forms of scoliosis usually have an underlying Arnold-Chiari malformation, which is a condition in which the brain tissue extends into the spinal cord, and a syringomyelia, which is a cyst forming in the spinal cord that can cause deficits as it expands in size. So the diagnosis of any type of scoliosis should instigate an investigation into possible comorbidities. Idiopathic scoliosis is very common in adolescents, but severe morbidity is seen mostly in children with early onset disease. This type of scoliosis will evolve during growth spurts, so the age of onset and severity of the disease are directly related. The earlier the age of onset and the more immature the bone growth at the time the scoliosis process begins, the more severe the outcomes. The patient from our case study discussed above was an adolescent female with an idiopathic scoliosis and a curve of 85 degrees. So neuromuscular scoliosis, these patients have the unfortunate situation where they have deteriorating muscle function in addition to mechanical distortion. So if you look at the slide, at the picture on the slide, you can see that the crowding of the ribs on the concave side of the curve is definitely going to limit chest wall expansion for these patients. And when they're sitting, you can see that diaphragmatic excursion is probably going to be restricted as well. So a couple disorders associated with neuromuscular sclerosis are included on the slide: Duchenne's muscular dystrophy, Prader-Willi syndrome, cerebral palsy, spinal cord trauma, and spina bifida. So our 13-year-old patient with idiopathic scoliosis had accompanying Prader-Willi syndrome, for which she had received growth hormone replacement therapy prior to her attempted surgical correction of the curvature of her spine. And despite the complications experienced during her case, which will be discussed again shortly, surgery was pretty imperative so that therapy could be resumed as soon as possible. So just a little side note on Prader-Willi syndrome, it does result from a genetic defect on chromosome 15, and along with growth retardation, these patients may also have obstructive sleep apnea and issues with thermoregulation that may make the anesthetic management a little bit more challenging. Other forms of scoliosis can result from trauma, a vertebral or interspinal tumor, or secondary to a type of mesenchymal disorder, such as Marfan syndrome, osteogenesis imperfecta, or arthrogryposis. Scoliosis curves can be classified in many different ways. The most popular method to measure the magnitude of the scoliosis curve is the Cobb method. This orthopedic gold standard for the assessment of scoliosis is measured by examining the antero-posterior radiograph and determining the most tilted vertebrae in each curve. Lines are drawn along the top of the superior tilted vertebra and the bottom of the inferior tilted vertebra. 2 more lines are drawn at an angle of 90 degrees to these lines, perpendicular so that they intersect. The resulting angle at that intersection is measured, and the number is expressed in degrees. With curves greater than 60 degrees, you'll start to see impacts on vital capacity in your patient's PFTs. And at curves greater than 100 degrees, their pulmonary function will be significantly impaired. If you remember, our case study patient had a scoliosis curve measurement of 85 degrees, which did have an impact on her pulmonary function, as evidenced by an FVC of less than 78% of predicted values. So another way to classify scoliosis is the Lenke classification system, and this is just mostly used by orthopedic surgeons to help them categorize the curve and then make decisions regarding surgical procedures on how to treat that curve. The 3 components to this classification system include the curve type, a lumbar spine modifier, and a sagittal thoracic modifier. So basically it's just a lot of technical jargon that ends up with there being 6 main types of curves. Types 1 through 4, the thoracic curve is the major curve, and types 5 and 6, the thoracolumbar lumbar curve, is the major curve.
Scoliosis causes a restrictive lung disease. Pulmonary impairment correlates directly with the magnitude of the thoracic curve. Anatomical changes in the chest wall cause decreased chest movement and impaired compliance, so you will see a restriction in the lung volumes. The largest decrease is in vital capacity. FEV1 will also be decreased. Less than 50% of predicted for both of these values is a major predictor of post-op pulmonary complications. The patient in our case study had a normal FEV1 and an FVC that was less than 70% of predicted. She had decreased pulmonary function, but did not fall in the higher risk category for post-op pulmonary complications. In addition, those with scoliosis have impaired respiratory muscle function. The chest wall deformity causes inspiratory muscles to work at a mechanical disadvantage. They will have ineffective coughing, which leads to atelectasis, pneumonia, and even respiratory failure. They will also have a VQ mismatch, which leads to arterial hypoxemia. These patients will present with hypoxemia, hypercarbia, and frequent lung infections. The big point I want you to remember is that the severity of the scoliosis is the most accurate predictor of impaired lung function. Cardiac complications. So, the chronic hypoxemia that these patients have is going to lead to hypoxic pulmonary vasoconstriction, HPV. This causes pulmonary vascular remodeling, which will lead to pulmonary hypertension. Pulmonary hypertension is more severe with the greater the curve of the scoliosis. The pulmonary hypertension is causing right ventricular hypertrophy, which can then lead to right ventricular heart failure. Mitral valve prolapse is also found in about 25% of all patients with scoliosis. It's also important to remember that scoliosis is often associated with congenital heart defects. The patient in our case study presented with an asymptomatic ventricular septal defect, which is a common association.
Body casting is a treatment for scoliosis that is useful in children with smaller, flexible spinal curves that are measured to be around 30 degrees. If casting is started before 20 months, successful spinal correction can be seen with curves as great as 60 degrees. The anesthetic for the patient undergoing a body casting procedure is best managed as a general with tracheal intubation. General anesthesia with an ETT is required to facilitate the positioning of the child, stretching of the spine, and maintaining relaxation while molding of the body cast is completed. As you can see in the picture on the top right-hand side of the slide, the positioning and casting process is not something that a pediatric patient will tolerate without a general anesthetic. After induction, the child is positioned on the frame, securing the pelvis to the caudal end of the frame and tethering the head by a chin strap to the rostral end of the frame. This is going to cause the spine to be mildly distracted, but the maneuver derotates the spine through the ribs and allows for the appropriate positioning for casting to take place. If you look at the picture, you can see that the chin strap used to facilitate the spine stretching has the potential to cause compression of the ETT after it is applied and tightened. So you want to make sure to place an oral airway in your patient prior to its application. The CRNA may see some desaturation when the cast is molded, but it's usually transient and self-limiting. After the cast is hardened, it's usually cut back and trimmed enough to maintain the correction of the spine while facilitating breathing, gastrointestinal function, and day-to-day living. The picture on the bottom right hand of the screen is what a cast would look like after it's been trimmed back. If casting is not appropriate or may be unsuccessful, another form of treatment for scoliosis is rods in spinal fusion. There are several variations to spinal fusion surgery, but almost all modern approaches will include the use of instrumentation. After the spine is exposed, hooks and screws are applied to anchor long rods to the spine. The rods are used to then carefully reposition the scoliosed spine. Once proper alignment is achieved, bone grafts are applied to the vertebral segments that are going to be fused. So the rods can kind of be thought of as splints that are going to hold that spine in place while the bone grafts take hold to support the straight shape. The fusion will take up to 12 months to completely set up, but once it is achieved, The rods, even then, are usually not removed because that just adds risks associated with another spinal surgery that isn't usually necessary. Now, if the rods are going to cause tissue inflammation or a lot of pain for the patient, they will be removed, but usually they're kept in. Harrington rods used to be more commonplace, but their use does require longer periods of immobilization and potentially worse patient outcomes. So now newer pedicle screws are used to offer better curve correction, and they may even decrease surgical complication rates. So basically, the overall goal of spinal fusion is the stabilization of that curve, and it can be accomplished via an anterior or a posterior approach. The anterior approach will require a thoracotomy for spinal accessibility, and it is also associated with a greater incidence of complications than the posterior approach. So keep this in mind when you're planning pre-op studies and intra-op management of these patients. For these pediatric patients, you're going to want to have a lot of information preoperatively. An echo and an EKG can be helpful to evaluate cardiac function and rule out potentially undiagnosed cardiac abnormalities. So as stated earlier, 25% of pediatric patients with scoliosis will also have mitral valve prolapse, and many patients have congenital conditions, as did our case study patient who had a VSD. Muscular dystrophy patients with scoliosis have a higher incidence of dilated cardiomyopathy, especially if they're presenting for surgery in their late teens. So you also want to have a good grasp on your patient's pre-op PFTs. If they have an FVC or an FEV1 less than 50% of predicted values, they're considered to have significant pulmonary compromise and will most likely need mechanical ventilation or some type of CPAP or positive pressure ventilation in the postoperative period. The lab work you may want to strongly consider for these patients includes a CBC, a BMP, and even possibly an ABG if significant pulmonary compromise is present. And you also want to consider getting some coags. The posterior spinal surgery approach has a significant risk for large blood loss and hemorrhaging. So assessing fluid status and obtaining a CBC with a hemoglobin hematocrit is very important for these patients in the preoperative period. Also, pediatric patients with cerebral palsy and Duchenne's muscular dystrophy have increased blood loss during surgery, which may be worsened by the fact that they have prolonged PTs and a decreased factor VII activity. So coagulation studies are also a good idea in this population. So just like with other surgeries, and especially ones in which the patient's going to be prone, careful attention needs to be given to the positioning of that patient. You want to make sure that you're going to pad those bony prominences and protect the eyes. So we all know that the risk of post-op vision loss is high in prone patients, and it's even higher if the patient is going to have any type of hypotension during the surgery, if they'll have any significant blood loss, or if the surgery is going to last over 6 hours. So intraoperative management and care must be taken to avoid this complication. You also really need to take care to maintain body temperature and avoid intraoperative hypothermia. Not only does intraop hypothermia create worse patient outcomes, higher infection rates, and increased healthcare costs, any coexisting diseases can be exacerbated by slight changes in body temperature. Our case study patient had an accompanying Prader-Willi syndrome that made thermoregulation difficult at baseline. So her temperature maintenance could have been more challenging, but definitely more vital. So also, because controlled hypotension may be used in these spinal cases, you may want to consider insertion of an arterial line and continuous EKG monitoring for close heart rate and blood pressure control. So as Jordan had discussed earlier, the pediatric patient is more parasympathetically driven and more prone to bradycardia that may be refractory to treatment with vasopressors and anticholinergics. The case study being referenced in this presentation discusses how spinal fusion surgery was attempted 3 times. The first 2 attempts had to be aborted because once the patient was turned prone, she became very bradycardic and was refractory to pharmacologic treatment. Recovery was achieved only after the return to the supine position. Prior to the 3rd surgical attempt for this patient, a transvenous pacer was used to manage bradycardia, and surgery was successfully completed. Post-op investigation led the medical team to conclude hypervagal tone was the instigator of the patient's symptomatic bradycardia. You also may want to consider monitoring fluid status utilizing a Vigileo or a flow track to manage goal-directed fluid therapy for these patients. Just because the risk of bleeding and hypovolemia are so significant, you really want to have a good grasp on where they are and where you want them to be as far as fluid status goes. So another complication to be aware of intraoperatively for these patients is the possibility of an air embolism. So the epidural veins above the level of the heart will be exposed at points in this surgery, so you really need to have careful hemodynamic monitoring.
During any spinal surgery, there's going to be a risk for spinal cord injury. The risk is increased with a Cobb angle that's greater than 100 degrees, also in those patients with congenital scoliosis and those with kyphosis. Somatosensory evoked potential, which is SSEP, and motor evoked potential, MEP, monitoring are utilized to reduce complication rates. They work by stimulating a peripheral nerve and measuring the response to that stimulation using scalp electrodes. Injury to the motor tracts will indirectly affect the sensory tracts and will cause changes in the SSEP. When spinal cord function is significantly impaired, there's usually an increase in the latency and a decrease in amplitude in the SSEP, with eventual loss of signal. Anesthesia management during this monitoring is to maintain less than 1 MAC for your inhalational agents. We want to avoid nitrous oxide. It decreases the SSEP amplitude. Propofol also decreases amplitude, but it's okay to use if kept less than 100 mics per kg per minute. Ketamine is a good agent to use as it enhances SSEP and increases the reliability of the monitoring. You want to avoid neuromuscular blocking agents because they prevent the ability to monitor MEPs. Postoperative management for these patients, effective pain management is going to be key. They will have significant postoperative pain for the first 3 days following surgery. The surgeon can inject intradural morphine 2 to 5 mics per kg, which is helpful for the first 24 hours of pain. PCEAs containing bupivacaine and hydromorphone have been proven to be successful in pain treatment. You also want to avoid NSAIDs, as they are known to impair bone growth and fracture healing. Ventilation concerns with postoperative. When we're talking about pulmonary complications, the main things we'll see would be atelectasis, infiltrates, pneumothoraces, pleural effusions, and prolonged intubation times. For patients with an FVC that's less than 30 to 50% of the predicted value, they will usually require post-op mechanical ventilation, followed by extubation directly to CPAP. Many patients with these low vital capacities are unable to cough effectively, rendering them prone to postoperative atelectasis, pneumonia, and respiratory failure. It's important to note that PFTs will not reach baseline values until 1 to 2 months after surgery, so they will still require support for a while. This concludes our presentation on a case study analysis, description of scoliosis, discussion of treatment options, and anesthesia considerations for preoperative, intraoperative, and postoperative management of a scoliosis patient.